So immunotherapy has been one of the biggest breakthroughs in the treatment of cancer in the past few decades. It has resulted in an immense increase in the survival outcomes, specifically in patients with metastasized melanoma, but also in lung cancer and some other disease types. And it also has shown to be able to produce durable responses that can last for many years in a subselection of patients. So in this video, I will discuss the evidence for treatment with immunotherapy in older adults specifically, and I will also discuss some biomarkers that we might be able to use in the future to predict which older adults may get a response and which patients do not. So let's get started. So the incidence of melanoma in older adults will strongly increase in the upcoming decades. We already see this pattern in the past few years. And this is mainly due to aging of specifically Western populations, but also populations in more developing countries. So in this presentation, I will focus specifically on patients with metastasized disease. So I will not go into patients with earlier stages of disease, because the patients with metastasized disease are the primary indication for immunotherapy. So in previous years, before there was immunotherapy available, we were used to treat these patients with chemotherapy. In the Netherlands, we would usually choose dacarbazine for these patients. But these treatments had very poor response rates. Around 10 or 15% of patients responded, and there was a lot of toxicity involved. However, after 2011, the treatment options really changed in these patients. So first of all, targeted treatments became available, but these are generally only usable in about 50% of patients who have a BRAF mutation. Then the immunotherapy era started, and for this presentation I will only be discussing checkpoint inhibitors. But currently we still only see response rates around 20 to 40% in the best case. So what is the mechanism of checkpoint inhibition? So in treating patients with cancer, the immune system plays an enormous role. Specifically in melanoma, we know that T-cell responses are strongly involved in clearing cancer cells in different tissues. And we know that T-cell activation is crucial in order to get a good response and to have a longer survival outcome. So the most successful immunotherapies that are currently available are the checkpoint inhibitors. And checkpoints play a large role in the activation and also the downregulation of T cells. The two checkpoints that we are currently able to target are CTLA-4 and PD-1. So CTLA-4 plays a role in the interaction between antigen-presenting cells, so APCs, and T cells. By blocking the checkpoint of CTLA-4, the downregulation of T cells is prevented. So this means that the immune response will stay more activated, so to speak. Similarly, PD-1 plays a role in the interaction between tumor cell and T cell. So that is another place where it acts. That's probably also the reason why it is generally more successful than CTLA-4. And PD-1 is also one of the checkpoints that we can block. So if we look at previous randomized clinical trials in which these treatments were studied, we see that generally there were no differences in outcomes between younger and older adults. So we see that the positive results that were achieved in the whole population in the trials was also achieved in the oldest patients. If we then look at the toxicity in randomized clinical trials, and this is specifically for PD-1, anti-PD-1 therapy compared to chemotherapy, we see that the toxicity rates were much lower than chemotherapy, so that was really good news in that time, and this also applied to older adults. So the incidence of adverse events was lower than in chemotherapy, and also when comparing these outcomes with younger adults, these were not worse in older adults in the trial populations. There is, however, a very important remark that we need to make here, because we know that in randomized clinical trials, there is generally a large underrepresentation of older adults. So this means that there are generally few older patients who are included in these trials, and maybe even more importantly, these were all very fit older adults. So this means that they had a good performance status, which is here shown with the ECOG performance status, which goes from 0 to 4. And an ECOG performance status of 0 or 1 means that there are generally no limitations in daily activities. However, we know that for the general population of older adults, the rates of patients who do have some limitations in their daily activities, lies much higher. So this makes that trial populations are not representative for the true older population. This might mean that response rates or maybe toxicity rates could be different in older patients. If we then look at what were the effects of these improvements in treatments over time and how did this change our practice, I want to show you these data that were derived from the Dutch Cancer Registry. And here we see all patients that were diagnosed in the years that you can see here on the slide with primary metastasized melanoma. So this means synchronous metastasized melanoma. That is an important remark to know when we look at these slides. But as you can see, in recent years we tend not to treat anyone with chemotherapy anymore, and we see a large increase in the rates of immunotherapy but also targeted therapies that we give over time. However, these rates were generally lower in the oldest patients, so still the older patients are offered immunotherapy less frequently. This can have many reasons. If we then look at the outcomes for the different age groups over time, we see that for younger patients up to the age of 74, the overall survival outcomes of these patients has really improved over the past few years, as we would hope to achieve, obviously, because of the introduction of immunotherapy and targeted therapies. However, unfortunately for the oldest patients, there was no improvement in overall survival over time. So this might be explained by the fact that we tend not to treat the oldest patients so frequently. But of course, there can also be many other factors involved, and I will go a little bit deeper into that topic. So to summarize the results of these data, we saw an increased use of targeted therapy and immunotherapy, but this was less pronounced in older patients, and the improving survival that we saw for the whole population was mainly explained by patients under the age of 65. So what are possible explanations for this? So perhaps not all older adults might be referred to specialized melanoma treatment centers. So in the Netherlands, melanoma treatment of advanced and metastasized melanoma is centralized in 14 large hospitals. But maybe patients in smaller hospitals are not always referred to these centers. Perhaps this is due to a fear of toxicity and we are less likely to treat patients with these treatments. Or it is also very well possible that patients have an increased risk of dying of other causes, and this is called competing risks of mortality. Although in patients with metastasized melanoma, we know that the melanoma is frequently the cause of death in this population because it's such a lethal disease. Then, of course, there can be other aging-associated factors that interfere with these treatments. So, for example, patients that are very frail or have other health issues can be limited in the ability to endure anti-cancer treatments. And finally, an explanation might be that older adults are less likely to respond to these treatments, although the data I just showed you do not support this explanation. So if we then look a little bit closer to the outcomes of older adults specifically, these are data from the Dutch Melanoma Treatment Registry. And here all patients in the Netherlands who are treated in the 14 centralized centers are included. And again, you can see that the overall survival outcome of the oldest patients is poorer compared to the younger patients. However, if we look at patients who were actually treated with immunotherapy, and here you can only see patients who were treated with monotherapy, so either anti-PD-1 treatment on the left or anti-CTLA-4 treatment on the right, you can see that the percentage of patients who had severe toxicity, so adverse events grade 3 or higher, was quite similar to the randomized clinical trials and was not associated with age, nor was it associated with the WHO classification, so the performance status, or with the number of comorbidities. So this is actually quite promising. So even patients with multiple comorbidities did not have an increased risk of severe adverse events. However, if we did look at the reasons to discontinue treatment early, we saw that with increasing age, the chance of discontinuing treatment due to toxicity was higher. So most likely this is explained by the fact that older adults might be more likely to have lower grades adverse events that were not registered in these data. And this may result in early treatment discontinuation and maybe in a decreased efficacy. So that might be one of the explanations why we saw that the survival outcomes are still worse in the oldest adults. This assumption is supported by data from the elders cohort, which is presented here. And this was an observational cohort with patients of many different tumor types, mainly patients with lung cancer. So it's a bit different population here. But again, you can see that in the oldest patients, the chance of grade 1 and 2 toxicity, but also of grade 3 to 5 toxicity, increased with age. And also in this study, it was shown that a G8, so the geriatric age questionnaire, which is a way to screen for measurements of frailty in older adults, was associated with the chance of adverse events in patients treated with checkpoint inhibition. So again, we see that toxicity might be more important for older adults, even if it has only lower grades. So how should we interpret these data and what should we do with these findings? Well, the big challenge that we face when we want to treat our older adults with cancer in general is that it is very difficult to look at the patient and to really decide what the biological age of a patient truly is. So we are very used to just look at calendar age, and above certain cutoffs we might not offer certain treatments to certain patients. However, in older adults, it's much more important to really look at the individual health status of a patient to determine the true biological age of a patient. And ways to do this could be to use a geriatric assessment, for example, so to really look at the different domains that might change when we age. So, for example, physical performance status, comorbidities, polypharmacy, but also cognitive performance is important, social support systems and psychological complaints that might play an important role in older adults. So I cannot stress enough that it is important to look at older individuals individually and not simply make clinical guidelines for treatments only based on calendar age. One of the factors that plays an important role in the way that we age and the biological age that patients may have is the underlying changes that occur in the immune system. So we know that when patients age, especially their T-cell population also changes. And we know that patients that age in a more frail way, so who have more problems, have less naive T-cells, so T-cells that have not been primed before. And you can imagine that when you want to target these T-cells, in which we want to do with checkpoint inhibition, this might play an important role. So to give an example of changes in the immune system and outcomes in older adults, this is a study that was performed in a healthy population, so not in patients with cancer, and it showed that T-cell but also B-cell populations are different in patients with and without cognitive performance problems. So this shows that there is some form of interaction between the immune system and the clinical performance of patients. So on the other hand, we might also argue that the chance of having a response to immune checkpoint inhibition might even increase in older adults. Because in fact, the checkpoints that are targeted are also markers of immune senescence, specifically PD-1. And this is a study that looked at immune infiltrates in tumor cells. And it showed that specifically the occurrence of CD8 positive T cells, which were activated, was higher in the oldest patients. And in fact, the oldest patients also had better response rates. And that is shown in this slide. So as you can see, the cutoff for an older age was quite low, so it was at 62. But still you can see that the oldest patients had a larger chance of responding to anti-PD-1 treatment than younger patients. So this is just one small study, but still it is a promising outcome that might suggest that older patients might benefit from checkpoint inhibition, maybe even more than younger patients. So as I've discussed earlier in my presentation, unfortunately still only around 40% of patients has a response to immune checkpoint inhibition. So this means that for 60% of patients there is no effect of these treatments. So therefore the research field in immunotherapy in general, independent of age, is always looking into biomarkers that can predict the response rates in order to have something that can prevent patients who are unlikely to respond to endure the treatment and have a chance of toxicity, obviously. So possibly there might be some overlap between the biomarkers that are currently known for immune checkpoint responses that you can see here and the immune senescence markers that I shortly mentioned before. So if we look at the negative predictors of a response in relation to immune senescence, We know, for example, that, as I mentioned earlier, naive T-cell populations decline when patients get older. They also have less antigen-presenting cells, and also CMV status, which is a virus that is associated with long-lasting T-cell responses, can have a negative impact on the ability to respond to checkpoint inhibition. On the other hand, we know that suppressive immune responses are often upregulated in older patients, and again, this can have a negative influence on the chance to respond to immunotherapy. And finally, another factor that I've not previously mentioned in this presentation is that in older patients, specifically in frail older patients, there's often a chronic rate of low-grade inflammation with increased levels of, for example, IL-6 and CRP. And again, this has been associated with a decreased chance of responding to immune checkpoint inhibition. On the other hand, I just showed you the CD8 positive T-cell infiltration in tumors that was found to be positive in older patients, and we know that older patients more frequently have upregulated PD-1 expression on T-cells, which might be beneficial for their responses. So, in my personal opinion, I think this is a field that we should look into in much more detail, but so far there are only limited studies that really look at these predictors of outcome specifically for older patients. So to summarize and to conclude, we see that there is a poorer overall survival outcome with increasing age in older adults with metastasized melanoma, and there have been no improvements over time despite the introduction of immunotherapy in the oldest patients, unfortunately. We see that older adults are less likely to receive immunotherapy if they have metastasized melanoma. However, we did not observe any differences in toxicity or response rates, although it was shown that older patients have an increased risk of grade 1 and 2 toxicity, which may also have a negative impact on the ability to endure these treatments. As a result, we see slightly more treatment discontinuation in the oldest age groups, which is possibly due to a lower grade toxicity. So future studies should really focus on, first of all, geriatric predictors for toxicity response and mortality, because these have been associated, for example, in chemotherapy with outcomes and are quite easy to measure. Also, I think we should look much more into immunological markers of aging and response, because it's very likely that these can really play a role in predicting which patients can benefit from these treatments. And we should also focus more on relevant outcomes specifically for older patients, such as quality of life or functional decline. And these topics have also not been studied very frequently in older adults specifically. So I really hope this was a helpful presentation, and I want to thank you all for your attention. So thank you so much.